Molt bon dia a tothom. Benvinguts i benvingudes a la jornada Alzheimer, avenços globals en recerca i tractament. És un plaer retrobar-nos avui aquí, una vegada més, al CCCB, per compartir coneixement, experiència i esperança al voltant d'un dels grans reptes de salut del nostre temps. Avui comptem amb investigadors i referents internacionals que ens ajudaran a entendre millor on som i cap a on anem en la recerca i en la prevenció de l'Alzheimer. Per inaugurar aquesta jornada és un honor convidar a pujar a l'escenari a la presidenta de la Fundació Pasqual Maragall, Quina Maragall. Gràcies, Quina.
Molt bon dia a tots i a totes. Benvinguts i benvingudes a aquesta tercera jornada del Brain Film Fest 2026, que va obrir les portes dimecres i que presenta activitats fins diumenge a la tarda. Us animo a que feu una ullada a la programació, els que no ho heu fet, i us animem a acompanyar-nos. És un plaer donar-vos la benvinguda a aquesta jornada especial dedicada a aprofundir en els avenços globals que s'estan produint en la recerca i el tractament de la malaltia d'Alzheimer. Des de la Fundació Pasqual Maragall hem considerat imprescindible abordar aquest tema en el marc del festival i ho hem volgut fer comptant amb el coneixement, la perspectiva i la visió de figures internacionals rellevants en aquest camp. Abans de començar, però, volem agrair-vos sincerament la vostra assistència a tots, autoritats, ponents, investigadors, professionals, representants institucionals, persones sòcies i participants als estudis de la Fundació, estudiants i ciutadanes interessats en conèixer millor com funciona el nostre cervell. Gràcies a tots per ser aquí. La Fundació Pasqual Maragall treballa des dels seus inicis amb una ambició molt clara, aconseguir un futur sense Alzheimer. Com molts de vosaltres coneixeu, la Fundació va néixer després que el meu pare, en Pasqual Maragall, anunciés públicament el seu diagnòstic al novembre de 2007. Aquest gest generós va ajudar a posar la malaltia al centre del debat en aquesta ciutat, en aquest país, i va propiciar el naixement de la Fundació compromesa en la recerca de solucions mitjançant la ciència. Des de 2008, la nostra feina s'ha focalitzat en impulsar la recerca científica en la prevenció de la malaltia d'Alzheimer. Ho fem a través del Barcelona Beta Brain Research Center, el centre de recerca de la Fundació, i també amb les beques de recerca Pasqual Maragall Researchers Program, que donen suport a projectes d'investigadors de centres de recerca espanyols. La nostra activitat científica no seria possible sense el compromís i la participació de la ciutadania. Aquest és un dels grans valors de la Fundació Pasqual Maragall. Milers de persones que de forma voluntària participen als nostres estudis de recerca i compten també amb el suport i la confiança de milers de socis i sòcies. Hi ha gairebé 115.000 a tot Espanya que amb les seves contribucions fan possible els nostres projectes i les nostres activitats. Alguns d'aquests esteu aquí. La Fundació Pasqual Maragall vol contribuir també a transformar la mirada social sobre l'Alzheimer. Això és important. Ho fem donant suport a les persones afectades i cuidadores, amb una intensa activitat de comunicació i divulgació sobre la malaltia, així com posant damunt la taula el pes del seu impacte i la necessitat de prioritzar el seu abordatge. El Brain Film Fest té com a objectiu la sensibilització i la divulgació del coneixement mitjançant la cultura. Un canal excepcional per explicar allò que no sempre és evident, per transformar missatges en emocions i generar consciència entre públics diversos. Aquest festival va néixer amb una idea molt poderosa, apropar la ciència del cervell a la societat a través del cinema, generant una plataforma de trobada entre disciplines i de reflexió conjunta. I parlar del cervell és parlar de les seves meravelloses capacitats però també de la seva fragilitat, d'allò que l'amenaça i de la necessitat de tenir-ne cura. Perquè el cervell no és només un objecte d'estudi científic, és memòria, emocions, identitat, creativitat, llenguatge, és allò que ens fa ser qui som. I quan el malalteix, també es transformen aquestes dimensions de la nostra vida. Per això és tan valuós impulsar espais com aquest, on la ciència i la cultura dialoguen, on el coneixement es trasllada a la societat i on podem reflexionar col·lectivament sobre els grans reptes del nostre temps. Durant el matí d'avui tindrem l'oportunitat d'escoltar experts i expertes de referència internacional que ens ajudaran a entendre millor en quin moment ens trobem i cap a on avança la recerca de l'Alzheimer. Quin és l'escenari actual de la investigació de l'Alzheimer? De quina manera els avenços en detecció precoç i nous enfocaments terapèutics modificaran el seu abordatge? Fins a quin punt la cooperació internacional pot accelerar el camí cap a un futur sense aquesta malaltia? Amb aquestes qüestions com a punt de partida, presentem enguany una jornada internacional que vol oferir una mirada actual i global sobre els avenços més recents en aquesta malaltia, abordant la prevenció, els nous tractaments i altres línies emergents de recerca. Per començar, parlarem de detecció precoç, biomarcadors i eines diagnòstiques, factors de risc i prevenció, de la mà de la doctora Sylvia Villeneuve i la seva conferència Understanding Alzheimer's Before Symptoms, From Early Detection to Prevention. A continuació abordarem els reptes, les oportunitats i els nous camins que s'obren en el desenvolupament de tractaments i estratègies de prevenció. Ho farem amb la taula rodona Addressing Alzheimer's in the Future, Advances, Challenges and Opportunities, moderada pel doctor Salvador Massip i amb la participació de Hilary Evans-Newton, directora executiva d'Alzheimer Research UK, i el doctor Arcadi Navarro, director general de la Fundació Pasqual Maragall. Per acabar la jornada, ho farem amb cine, evidentment. Gaudirem d'un documental sobre Ramon i Cajal, on veurem com la curiositat i la mirada artística de Cajal van obrir camins imprescindibles i que encara avui són font de coneixement i d'inspiració. Per començar aquesta jornada tenim el privilegi de comptar amb una investigadora de gran prestigi reconeguda internacionalment. La doctora Sylvia Villeneuve és professora associada de psiquiatria a la Universitat McGill de Montreal, titular de la càtedra de recerca del Canadà en detecció precoç de la malaltia d'Alzheimer i directora de la cohort Prevent AD. El seu programa de recerca se centra en la detecció precoç i els mecanismes de la malaltia d'Alzheimer, amb un focus important en els biomarcadors de neuroimatge, els biomarcadors en fluids i les diferències entre sexes al llarg del continu de la malaltia. Un dels objectius principals de la seva recerca és identificar factors modificables i marcadors sensibles que permetin millorar l'estratificació del risc, això vol dir la seva definició, i orientar estratègies d'intervenció primerenca. El treball de la doctora Villeneuve contribueix de manera decisiva a apropar-nos a un futur en què l'Alzheimer es pugui detectar i tractar. I precisament de tot això ens parlarà avui. Sylvia, it's a great honor to have you at the Brain Film Fest to open this session. The stage is all yours. Thank you. Gràcies a tots i esperem que gaudiu molt de la jornada.
Hi everyone, can you hear me well? Yes, excellent. It's absolutely a great honor to be here today. Thank you so much for the invitation. This is a cause that I think is very important for all of us. So my grandma has had Alzheimer's disease actually many years ago. And then she actually had the disease when it was with memory impairment for more than 20 years, which is quite unusual. And we're going to discuss today a little bit why it could be the case. Is that working? I think it's on the other computer, right? Ah, okay. Okay, sounds good. Okay, so again, thank you so much. So I would first like to start by thanking the funding agency. So what we're doing is really costly, it's really important, it needs money, so thank you for that. My trainees, my research staff, and then, of course, the participant. Without the participant, it would never be able to understand the disease in its preclinical phase. The disease spans over decades, so we really need to have participants that are willing to stay with us for a long time. This is extremely important. So the presentation today will be divided in 4 sections. So first of all, we're going to talk about the preclinical stage of the disease, how can we identify it, and then on the second part, we're going to move to how do we think that we can prevent it. And one more. Okay, so Alzheimer's disease is a continuum. So it starts. I do have many animation. Do you think I can take the computer or here? Would that be possible? No, okay. So Alzheimer's disease is a continuum. So first of all, so when we talk about Alzheimer's disease, most of you would say, well, Alzheimer's disease is a disease that creates memory impairment and other type of cognitive impairment. It is right, and then this phase of the disease spanned between 5 to 10 years. As I told you, my grandma was in this phase for more than 20 years. Before that phase, there is the preclinical phase of the disease, where disease starts to take place in the brain, but then there's no symptoms. So this phase usually spans between 15 to 25 years, and then the transition between these phases can be influenced by our lifestyle, by our genetic, and by other factors. My grandma had no education, and we know now that education can protect us not only toward getting the disease at the first place in the brain, but then also toward developing cognitive impairment. So probably she had the disease for the same time as other person, but because she had less reserve, how we called it, less education, this clinical phase was longer, and then the preclinical phase was shorter, which is not what we wish. We don't know how Alzheimer's disease starts, and this is one main area of research. We're trying to figure out what causes Alzheimer's disease, but what we know is that in our brain, we all have some amyloid and tau protein, which are what we think are elements that are important within Alzheimer's disease. So small pieces of amyloid, we all have that. My children have them in their brain, you have them in their brain. Part of it is the result of brain activity. It's kind of trash that we need to clear out. And then in Alzheimer's disease, in sporadic Alzheimer's disease, there is an imbalance between the production of these proteins and then the clearance. And then at one point, and we don't know why, these little amyloid kind of aggregate together, form plaque, and we think that this is what leading to tau to change in form and configuration. Thank you. And then we think that it's this tau, when they again agglomerate together, when they phosphorylated, that become really, really neurotoxic. That's going to lead to neurodegeneration, so atrophy of the brain, change in the brain function, and we strongly believe that this is what is causing the memory deficit. So the hope is that we can kind of stop the disease earlier, that we can make kind of these, that we can try to stop the disease at these different stages. So as I told you, the preclinical phase span over 15 to 25 years. So while that might be scary, it's also a place to try to intervene. Okay, so I'm leading the PreventAD cohort, and it's very, very similar actually to a fantastic cohort that you have here in Barcelona, so the Alpha study. Both cohorts actually share a lot of similarities. So these cohorts were started about 15 years ago with this vision of this preclinical phase and trying to better understand this phase to better try to prevent it. So this is really the idea. Here are kind of the main characteristic of the cohort. So we are enrolling people who are in their middle age, older age, and then everyone are cognitively unimpaired, but at increased risk of Alzheimer's disease because they have a family history of Alzheimer's disease. And this is just a snapshot of the type of data that we're collecting in the PREVENT-AD. And again, in the alpha study, it's very, very similar. So we have a focus on brain imaging. We want to see the pathology in the brain. We want to understand what's happening in the brain. I'm going to talk today about fluid biomarkers. So we also want to see what's happening in your full body. We want to look actually at all the protein in your body. And then for the PREVENT-AD, we have a main emphasis, actually for the alpha as well, we have a main emphasis on lifestyle, because we think that one way to try to prevent it will be to change our lifestyle. And what you can see on the right part of this graph is that every participant in the PREVENT-AD are seen every year. So every year we do lumbar puncture, we take a blood drawn, we do cognition to try to see how the disease is evolving over decades. Most of the participants are followed without intervention because we want to understand how the disease evolves over time. But then we are also proposing to our participant, when we think it's relevant, new intervention. So we did one, for example, targeting inflammation. We are doing intervention on lifestyle. And today I'm going to talk to you about an intervention that we're currently doing using a drug that is given for sleep, but then that we think might be able to prevent these proteins to build up together and then to be neurotoxic. So now, how can we identify these individuals in the preclinical phase of the disease? So if I go back to this slide, so we have... So if I go back to this slide, so since recently we have extremely good plasma biomarker. Again and again. Yeah, just give me 1 second. Okay, so we're gonna cut some animation. I think that it's not working well, but I'll still give you the take home of that. So since recently, we have been developing, we being the community, the field, we have been developing blood biomarker to look at the protein in the brain, to look at amyloid and tau in the brain. We think that these blood biomarkers are actually capturing early form of amyloid and tau, if you want to. And then so if we kind of go back a little bit in time, so in 2004, that was something big happened in the field of Alzheimer's disease, is that for the first time, we were able to see the protein, the amyloid, in the brain in vivo. So we were really able to track the protein and then the change of the protein in the brain in vivo. And then in 2013, when actually these two cohorts kind of started, then we had biomarker to image the tau in the brain. It's really hard to track a disease in its asymptomatic form when you don't have biomarker for it. So that really kind of changed the field. And then, so what do we know about, when you are positive on these biomarkers, when you have these biomarkers, and then your risk of progression to Alzheimer's disease? So what we know right now using these biomarkers is that about 25 to 30% of cognitively normal older adults, so people without cognitive impairment, have amyloid in their brain based on the amyloid PET scan. So this is what you can see on the right. So in the middle, you have someone that is cognitively normal with amyloid level that are as important as someone with Alzheimer's dementia on the right. So if you follow people that are amyloid positive on a PET scan for a decade, you will see a slight decrease in their cognition. Hopefully that's going to work. Okay, and then now that we have the tau biomarker, what we know is that it's actually the tau driving that. So when you're positive on an amyloid scan, risks are that you might also develop tau, image with PET, and then when you're positive on both, at a group level, these are the one declining. So when I started my job at McGill University, I decided to do PET scan on PREVENT-AD participant with the main question to ask at the individual level, who will develop cognitive impairment? So what I'm showing you here is a figure where I take the first 128 participants, I divide them based on their amyloid and tau PET biomarkers. So you have A plus, T plus, this would be people abnormal in both amyloid and tau. And then so when they do the PET scan, they're all cognitively normal. And then I'm going to follow them for 3.5 years. And then after 3.5 years, what we see is that more than half of the individual in the A plus, T plus group, so with abnormal amyloid and tau biomarker, unfortunately develop mild cognitive impairment. Now, what was surprising to us is that after this 3.5 years, only 9% of the one without amyloid developed cognitive impairment. So for us, that suggests that maybe if you only have amyloid and you don't have tau, you're kind of protected. So maybe actually it's not too bad. These findings, we replicated them in 3 other cohorts, found exactly the same thing. And the complex graph that I'm showing you, what they're suggesting is that other study worldwide using also PREVENT-AD and alpha cohort found the exact thing. So if you follow someone that has no cognitive impairment for a mean of 3.5 years, half of them, the one with amyloid and tau, will develop cognitive impairment compared to about 10% in the amyloid plus tau negative group. Now, it is extremely, extremely important to follow participants for a longer period of time, because with the follow-up, sometimes our conclusions change. So now I'm showing you the same graph, but now it's after 6 years of follow-up. And now what you see here is that, unfortunately, everyone that were positive both on amyloid and tau have developed cognitive impairment. 40% of them were at that time diagnosed with Alzheimer's disease dementia, so they couldn't do their activity of daily living. And now what's kind of novel in this graph is that now the ones that were just amyloid positive at baseline are starting to have cognitive impairment. So our conclusion has changed. I don't think anymore that being positive on an amyloid scan is just a risk factor. I think that they're just further in time. And when we look at the autopsy study, what it's suggesting is that our amyloid and tau PET scan are really good at identifying the pathology. If I see the pathology on the scan, you most certainly have the pathology in your brain. However, if your scan is negative, it is still possible that you have some level of pathology. So it's extremely specific to the disease, but it's not that sensitive at identifying people with the pathology. What about the plasma biomarker now? So this is one of the main studies in the field, and then what is showing is that we have now a panel of plasma biomarker that can help us identify these individuals who are positive on amyloid PET scan. And then if we go back again to the PREVENT-AD study and then we look at could plasma biomarker predict future progression to mild cognitive impairment or dementia, what we see is that if we take the plasma p-tau217 marker, and then if you're positive on that biomarker, the chances, or the risk I should say, are quite high that within a window of 10 years, so 1 decade, you will develop cognitive impairment. If you're also positive on the plasma amyloid marker, which are a little bit less valid, but still, if you're positive on both, then chances are that you might be close actually to more severe cognitive impairment, so more advanced in the disease. Now, a recent study that was just published suggests that if you take these plasma markers and then you look how far are you from being positive on these biomarkers, so we could say how abnormal are these biomarkers, that can also give you an idea of how far you are from developing cognitive impairment. So not only knowing that you're positive on a plasma biomarker tells you that you are at high risk of developing cognitive impairment, but also the level of abnormality can give us an idea of how far you are in the disease process. And this is extremely important because if you're 80 years old and we tell you, well, you're 15 years away to develop cognitive impairment, it's not going to have the same impact in terms of, for example, treatment, risk-benefit, than if you are, let's say, 80 years old and then we tell you, well, you're really close to developing cognitive impairment, unfortunately. Among the other plasma markers that are of high interest is the GFAP marker. It's somehow a surrogate for inflammation. We know that in cognitively unimpaired individuals with amyloid in their brain defined with PET scan, these individuals usually have higher GFAP values, so we think it's really related to the disease. I keep talking about amyloid and tau, but there's so many other things happening with the disease. And one thing that now we know is that females seem to have this marker of inflammation that over time increase more rapidly than in men. So we know that 2/3 of people living with Alzheimer's disease are female or women, so women are more at risk. And we think that here we have a key element on what could make women more at risk. So it is possible, for example, that things are happening in their brain, there's more inflammation, and then that this can probably potentiate the pathology. Now, if you're cognitively normal, it's not a good idea to do a plasma test to know if you're positive on the p-tau217, because while these tests are very powerful in changing the field, you can also have positive tests that are not due to Alzheimer's disease. These are my kids. The study, they were not part of the study, but the study here are suggesting that in newborn baby, and we don't know why, but the p-tau217 level are super, super high, way higher than in people with Alzheimer's disease. And after a few weeks of age, these levels kind of normalize. So what I'm saying here is that there are other factors that are influencing these plasma level. It's not just Alzheimer's disease. So when you're positive on a panel of plasma marker, you need further investigation. So to summarize this first part of the talk, so people who are positive on both amyloid and tau PET scan are at really, really high risk. In our cohort for the first participant, it was 100% of developing cognitive symptoms within 5 years. People who were only positive on the amyloid PET scan, they were at high risk of developing also cognitive impairment, but further away, so more within the kind of the 5-ish year window, so further away. The plasma p-tau biomarker, it's an extremely powerful biomarker. However, further investigation is needed if you're positive and you don't have the cognitive symptoms. That really makes us believe that you have Alzheimer's disease. Where do we see the future for these plasma biomarker? A little bit probably like what we're doing for vascular diseases. So to have a panel of biomarker and then to look at the profile of the person, and then with that to balance the risk of being in the preclinical phase of Alzheimer's disease. For the second part of the talk, we're going to talk about how do we think that we can modify this disease. So age is the main risk factor for Alzheimer's disease. I know that we all would want a world without Alzheimer's disease, but the older we age, the increased the risk is to develop Alzheimer's disease. I was just visiting one of your wonderful museums yesterday that have an exposition on time, and then I kind of realized that, if we want to live longer, there's also with that so many diseases that are coming, right? So I think that the idea, for me at least, is not, I don't think that it's going to be possible to completely remove Alzheimer's disease from the world, but I think that what we need to do is to push it further along, that we're going to die before the disease could develop in our brain. So this is my hope. So among the other non-modifiable risk factors, for sporadic Alzheimer's disease, it's being ApoE4 carrier. 25% of us are ApoE4 carrier, and that increases our risk of developing Alzheimer's disease. When we have a family history of Alzheimer's disease, that doesn't mean that we are ApoE4 carrier, but there's a little bit more risk that we might be carrying this gene. And as I said before, female, and particularly ApoE4 female, are at increased risk of Alzheimer's disease. This is a busy slide. I'm just going to walk you through it. So in the last few years, people have really devoted a lot of attention of which lifestyle factor might reduce the risk of Alzheimer's disease. Here are the main lifestyle factors that have been identified. The first one is education. And what we found in the PREVENT-AD data, but also we replicated in the DIAN study. So 1% of people with Alzheimer's disease have a genetic genetic penetrant form of Alzheimer's disease. We're not talking about ApoE, we're talking about other gene. If you have these genes, usually you have the disease earlier in time. And if you have the gene, unfortunately, you will develop the amyloid tau and then the symptoms. So in both of these cohorts, sporadic and autosomal dominant Alzheimer's disease, what we found is that in cognitively unimpaired individual, the one with more education had less amyloid in their brain. In the DIAN study, in these persons with the genetic mutation, they will develop amyloid, but we think that education by some mechanisms might be able to protect them a little bit longer. Among the other factors that we have, the data that we have collected in the PREVENT-AD, so what we found is that tau was related to hearing loss. I'm not sure if this is a cause or a consequence. Physical inactivity was an increased risk for both amyloid and tau. And then smoking, excessive alcohol use, and social isolation were all risk factors to have more amyloid in your brain. One surprising thing here, for those of you knowing the field, is that the vascular disease or risk factors, such as hypertension and cholesterol, are not highlighted. Actually, they are. So in the cohort, in the PREVENT-AD cohort, people are well treated for the vascular risk factor. And it's only in the one that are not taking vascular medication that we see this harmful association between vascular risk factor and the pathology. And what I believe, and we are studying that, is that I think that some medication for cholesterol and for hypertension might in fact be protective toward developing amyloid in your brain. Okay, very, very busy slide. I'm going to walk you through it. So here what we did, so we have so many data in the PREVENT-AD, right? So here what we did is that we did multi-factor analysis. We took all the information that we had about lifestyle, and then we looked at all the brain region. And then what we're looking at is the correspondence between what is associated between the amyloid at first in the brain and where in the brain, and then which lifestyle factor are related to this amyloid. So the way to read this graph is that it kind of like, these are the amyloid brain region that are related to these lifestyle factor, and this goes with tau. So tau within these medial memory-related region, and in which risk factor or protective factor are related to the pathology. So what we're finding here is that mindfulness, so being able to be in the present moment without judgment, what kids are so good at doing, right? They go to the park, they see a bird, and then they just think about the bird. Think about us now. We go to the park, I think about my talk, I think about my job, so that's not good. So being able to be in the present moment without judgment in our data set seemed to be really powerful, to be related to reduced risk of both amyloid and tau. For tau, actually, the main driver of tau was purpose in life, and we have some autopsy studies suggesting that purpose in life actually, people who had more purpose in life at autopsy, when we looked at their brain, had less pathology. So I think that there's something there. Some of the factors we already discussed, so higher education, higher physical activity in that case were related to a reduced risk of amyloid. On the tau side, it was more optimism and again, physical activity. And then when you're looking at the bottom part, so which factor puts you at increased risk, if you just could put it back for one second, thank you. Increased risk of both amyloid and tau, so what you see is that factors, so psychological factors such as apathy, stress, social isolation, perseverative negative thinking, which is a little bit the inverse of mindfulness, or ruminating, were all related to increased risk of amyloid, and then stress, apathy, and again, perseverative negative thinking were related to tau. And then the last study that I want to show you before I go to the clinical trial that we're doing in Montreal is that I talked to you about ApoE4, right? So again, 25% of us are ApoE4 carrier. And then at a group level, we know that ApoE4 really have a higher risk of having amyloid in their brain. They develop amyloid earlier on, and we think that it's really how with other mechanisms, but this is one of the mechanisms why APOE4 carrier are more at risk of Alzheimer's disease. But when I was doing my postdoc with one of my very, very good friends, Miranka Ward, we were also interested at the individual level, right? Always asking, okay, you have a genetic risk, but is there something that could buffer this risk? And then what we found is that looking at individual one by one, we have some APOE4 that will never develop Alzheimer's disease, that will never have amyloid in their brain. So we asked the question, who are they? And one thing that we found is that APOE4 carrier that were throughout their life doing a lot of cognitive activities, such as attending a presentation like this today, writing letter, reading books, going to the museum. So people who were having their brain being engaged throughout the life had lower risk of having amyloid in their brain than the APOE4 with lower cognitive activity. To the point where, like, when we look at the group level, APOE4 that were doing high cognitive activity throughout their life were not more at risk of having amyloid in their brain than the non-APOE4. So really suggesting that our lifestyle can have an impact on our genetic. For the last few slides, so now how can we maybe use that to try to intervene? So this slide is showing you all the clinical trials that are being run, or that have been run, I should say, in 2025 for Alzheimer's disease. So the first thing to notice, I mean, of course you cannot read that, but I'm going to tell you what is it important in that slide. So the first thing to know is that the trials are not just about amyloid and tau, right? Alzheimer's disease is this complex, multifactorial disease. It's like cancer. If we want to treat it, we probably need to go multifactor. So, you know, people are targeting amyloid, tau, but then again, also inflammation, the level of APOE in the brain, and then other pathways. So this is all the trial for Alzheimer's disease. Now, these are the trial when I restrict it to the preclinical phase of the disease. And when I see that, I'm scared or I'm sad or whatever the feeling, but I don't like it, right? There's not enough trial, according to me, devoted to the preclinical phase. Because again, I think that what we want, at least for our children, is to try to stop the disease before we even have cognitive impairment. And it's probably way easier to stop it at that point. Again, think about cancer. We don't wait until you're super, super far in the disease to try to intervene. It is easier to intervene when you are earlier in the disease. And I think that for Alzheimer's disease, we need to find the same, we need to have the same mindset. One reason why it's so hard to do a trial in the preclinical phase of the disease is because of the risk of the treatment, right? How do you balance risk-benefit? So now I'm going to make a link to the first part of my presentation, and I think that if we have the biomarker that can not only tell us if we have the disease in our body, but also when are we going to have symptoms, then we can better advise the participant or the patient if they should or not enroll in these kind of trial, right? Because again, if you're 15 years away from developing symptoms, it's not the same as if you're in your early 60s and you're like 2 years away. So in the PREVENT-AD, as I told you before, we are sometime running clinical trial. I'm currently running a trial using a DORA drug. So DORA are dual orexin receptor antagonists. It's a drug that is used for sleep. It's not like the Z drug or the benzo. So it's a drug that it doesn't put you to sleep. It reduces your wakefulness. It's a very, very different pathway. So not all the drug have for sleep might have the same impact. We know that sleep is probably one of the main processes by which we are able to clear these little fragments of amyloid before they go into plaque. Sleep is extremely, extremely important for maintaining the health of the brain and also to probably clear some part of the pathology. Few years ago, there was a clinical trial that was done where they gave a DORA drug, so sulvorexin, to participant middle age, no risk of Alzheimer's disease, and then they looked acutely within taking lumbar punctures, looking in their CSF, so a liquid that go into the brain, if taking that drug for an acute phase was having an impact on their Alzheimer's disease biomarker, and they found that it did acutely. And then after that, even more promising, this kind of a related group showed that in mouse model of Alzheimer's disease, so mouse model that we give them Alzheimer's disease, not sure how to say that in English, but so in mouse model of Alzheimer's disease, the one that we're taking, the DORA, actually had less atrophy after a few months than the one taking other sleep drug or a placebo, had less phosphorylation of the tau, and then also had a methylation within their microglia, so kind of the, let's say, inflammatory system. So really suggesting that this drug could be beneficial for your brain when you face Alzheimer's disease. So what we are doing at McGill, so we are currently running that, so we are enrolling 200 participants. Half of them will take a DORA, so daridorexant, the other half will take a placebo. And then we're following people for 1 year, we're taking a few blood tests, and the outcome, as you might expect from my presentation, will be p-tau 217. That's really the primary outcome. We will also look at change in cognition and sleep, but really what I'm interested in is pushing the biology at this stage of the disease. So to kind of conclude, or what are the future perspectives? So I started my career looking at the clinical phase of the disease. I'm running my lab looking at the preclinical phase of the disease and also my preventive center. Where I want to go next, I want to go even before that. I want to understand why do some people build up this amyloid in their brain, because I think that if we can stop that from happening, we could probably maybe have a world actually without Alzheimer's disease. We already have some cues, right? So we know that ApoE4 is a risk factor. We need to understand why. ApoE4 is the ancestral allele. So at one point in history, it was a good thing to be an ApoE4 carrier. And I was just having some very good discussion here. Probably still, as of today, for children, it's a good allele to have. But with time, again, something happened that is not protective anymore. What about the lifestyle? I mean, I tell you mindfulness might be protective, but why is it the case? We need to understand that. I have some ideas if we have questions after. And then finally, if you look at when the symptoms start, if you look at when the preclinical stage start, and then you kind of go back 15 to 25 years ago, what's happening at that time is menopause. We know that women are twice at risk of having Alzheimer's disease. We know that their vascular system change in that phase. We know that there's more inflammation. So could it be that the change happening in menopause create a perfect place for the amyloid, for example, to aggregate, for the tau to phosphorylate? So I think that more emphasis absolutely need to be done, put on women's health, and then understanding what might happen to them, and also, what hormone therapy could have as a protective or a bad effect on that phase. So to conclude, cognitively normal individual with positive amyloid and tau PET biomarker will develop symptoms if not treated. They will develop the clinical form of Alzheimer's disease if not treated. So we need to find a way to treat them. We should aim at slowing down or stopping the disease before clinical onset. Of course, we need also to, to slow it down when people have cognitive impairment, but I think that really we need to devote a lot of attention there, and even probably before amyloid start to aggregate. Plasma biomarker are a super powerful tool to identify potential candidates for preventive trial. And then lastly, preventive intervention need to be multifactorial. Again, I talked about a lot of amyloid, a lot about tau, but there's so much thing happening there. So we need probably also to, again, use a strategy as it was done in cancer. Look at multifactorial information at the good time window. And an increased effort need to be done toward an ApoE4 carrier that in some of the trial respond less than other, and in female for whom we know they have twice the risk of developing Alzheimer's disease. With that, I thank you for your attention.
Thank you very much.
My pleasure.
Moltes gràcies, doctora Villeneuve, per aquesta exposició tan clara i tan enriquidora. Ara obrirem un torn de preguntes. Si us plau, només cal que aixequeu la mà i us prepararan un micròfon i podreu fer la pregunta que vulgueu a la doctora Villeneuve. Aquí veig una mà aixecada i allà en veig una altra. Veig bastantes mans. No sé si veig com a 4, no sé si tindrem temps de fer tantes preguntes, i celebro que hagi despertat aquest interès, com era de preveure, l'exposició de la doctora Villeneuve. Endavant, sisplau, digui'm el seu nom.
Jordi Martínez. Bon dia, doctora, benvinguda. Ha parlat del factor son?
I don't have the translator, so I'll go. That's going to be hard.
Detall important. Un momentet.
I do have this one, I think.
I de seguida escoltem la seva pregunta i intentarem això, que si són ràpides i àgils, que hi hagi el màxim de preguntes possibles. Abans de la taula rodona, que tindrem d'aquí uns moments. A veure si ara és possible. Doncs endavant amb la... Fem la pregunta ja? Estem preparats? Estem comprovant que funciona. Sí, endavant, doctora Villeneuve. Sisplau.
Deia que bon dia. Ha parlat en la seva exposició del factor son i també retruc una mica el factor activitat. En quant al factor d'alimentació, heu fet algunes proves, heu arribat a alguna conclusió en el vostre estudi?
So it's an excellent question. We have so far our result on eating is not that conclusive. However, I think that one of the paths by which, so again, I'm going back to the ApoE4, right? So ApoE4 is an allele that is important for cholesterol transport in the brain. It's an allele that's related both to Alzheimer's disease and then to the vascular system. And then again, ApoE4 carrier is the ancestral allele, right? So like back in the days, it was good. What have changed so much, between like many years ago and then now, is probably the physical activity and the eating habits, right? So like we are always eating, we have food as we want, and I'm kind of wondering to some extent, is it possible that ApoE4 carrier are less adapted to these eating habits, right? So I think that when we think about eating habits, at first I was not that keen on that, but they are now increasing study looking at fasting. I don't think that fasting is good for everyone, but allowing your body not to have food, not to be digesting food for a certain period of time, right? And I'm kind of wondering if for ApoE4 carrier that could be good to some extent. So again, the body, and it's a little bit the same about the mindfulness, right? We are always in action. We're always thinking, we're always on our phone, we're always eating, but the body at one point needs to be able to clear the trash. I'm going to put it like that, right? So when you're not digesting, then you can, be able to clear other, again, sorry, I speak French, right? But I think that you get the point. So I think that the eating habit will be extremely important to look at. I think also that particularly in women, when the menopause arrives, I think that we need to be careful about, the point is not to eat less, the point is to have enough energy for our brain to function with the change, right? So I'm not a big fan of diet without any fat and things like that. So I think that your body needs to be able to kind of change your food into ketone, give energy to your brain. So I think that there's absolutely something that needs to be look for the diet. So it was a long answer, but I think that there's two things. I think that our body and maybe the ApoE4 carrier their bodies not necessarily adapt to eat all the time as we're doing. And I think that we need to put more attention of what should be eaten. And the field is suggesting that Mediterranean diet is actually quite protective, right? So good fat, good fish, and things like that is probably olive. These are probably things that your body need actually to get some energy.
Gràcies per aquest resum. Donem pas a una altra pregunta. Li apropem el micròfon aquí, a la primera fila, i a la tercera o quarta també demanen torn.
Hola, bona tarda. A veure, abans que comencés el Covid, jo vaig entrar en un estudi de la Fundació Maragall per veure si era susceptible de tenir Alzheimer.
Oh, yeah, I do. Yeah.
Vaig sortir positiva, o sigui, de la PUA, de 4, tinc 3 possibilitats de desenvolupar Alzheimer. El que va passar és que quan va començar el Covid, jo tinc asma, no podia portar mascareta, aleshores em van eliminar del grup i no van provar res amb mi. O sigui, uns provaven un placebo del té verd, uns era placebo, els altres era té verd i jo era nada. Bueno, m'he quedat una mica orfa perquè no sé res de què passa amb mi.
I la pregunta és?
I la pregunta és, què puc fer? Què puc fer? Perquè jo menjo molt peix, vaig al mar, em banyo també a l'hivern, vull dir, intento fer coses saludables, però aquesta nit he tingut un somni horrible i m'he despertat que no me'n recordava de res, avui. I això, no m'espanto perquè crec que sóc una dona forta, però he arribat fins aquí per intentar recordar com arribo al CCB. No ho sé. Si em pots dir alguna cosa, t'ho agrairé.
Escoltem a la senyora Villeneuve.
So, absolutely. So I only heard half of it. Gemma, are you in the room? I think you are, right? Could you come close? No, she's not? Could you come closer so then maybe you can thank you. So I will have my personal translator and friend. No, but I think that I got most of it, right? So I think that there was a part about COVID, right? And then so one of the things, so yes, eating and things like that, but it is really, really, really important to have stimulation of the brain, right? So I think that one of the things is that when COVID happened, everything, it was scary how many individuals that were kind of borderline having cognitive impairment just started to have cognitive impairment, right? So when I'm talking about this preclinical phase and then this clinical phase, I think that with the social isolation, we just kind of moved everything, right? Like people were getting faster in the clinical phase. So yes, have a network, have friends, have discussion that are stimulating and things like that, right? This is one part. The other part that I get was about the dream and things like that. So when we are stressed, our memory is not functioning properly, right? Think about it. We are asking so many things to our brain and our body. So the brain is making sure that he's paying attention to what is important, right? Let's think, so some of you are probably part of the cohort where you're doing these memory tests every year. Think about you going to the center to do your memory test, and then unfortunately going there, you have a car accident. There's no way you can do the cognitive test. You might not even remember that you went to the center that day, right? Because what you remember is that you were in a car accident, and then your body is kind of in this danger phase, right? So it's not the time to remember the mots, the word that are given to you, right? So sometimes we're very stressed because we have the impression that our memory is not working well. Sometimes it is the case, right? But sometimes also it's because of the factor around us. So again, if you're stressed about something, your brain will not be there to try to be, kind of attentive to what's happening. And then you might have, more cognitive difficulty. So we need to be very careful about what we mix up. Thank you. Do we still have time or yeah?
If I can say
Yeah,
something.
absolutely. An expert here, so.
No, we can talk to you later and discuss further.
Are we running out of time? Yeah.
Sorry.
I'll let you
Perfecte.
translate, okay, if that's fine? Okay, perfect.
Sí.
Donem pas a una altra pregunta. A la tercera i dissortadament serà ja la darrera perquè si no ens anem endarrerint.
Va bastant en relació amb les dues preguntes que han fet abans, que ja han contestat part del que volia preguntar. Jo el que voldria saber és què podem fer aquí, a Catalunya, i ara, per saber si podem patir la malaltia aviat. Jo explicaré per què m'interessa això. Soc cuidadora de 4 persones amb trastorns mentals, més joves que jo, i aleshores penso que no em poden cuidar. I tot el que jo pugui fer per endarrerir, si és que perquè hi ha un antecedent familiar, per endarrerir l'aparició de la malaltia i per poder-me cuidar jo mateixa. Aquí què es pot fer? Des de l'assistència del CAP fins
I parla aquí a Barcelona. No sé si ara esbrinarem si la doctora Villeneuve té resposta a aquesta pregunta seva. Gràcies.
Yeah, I think so. I got this one. So absolutely right. So Canada is quite different, and then you have amazing resources here. I've been impressed every single day that I'm here about everything that can be offered. So I think that yes, going to these resources is absolutely the first place to go. It's not because we have a parent that had Alzheimer's disease, or even because all our siblings have Alzheimer's disease that we're going to develop Alzheimer's disease, right? It's a risk factor, but then it's not a cause, right? Same thing for APOE4. So it's not because we are APOE4 carriers carrier that we're going to develop Alzheimer's disease. And the inverse is also true. You might have no parent with Alzheimer's disease, but develop Alzheimer's disease, right? So I think that we really need to be careful there. And I think that in terms of prevention, as of now, this is really trying to change the lifestyle. And I think that for me, the best preventive way is to be aggressive on the vascular treatment. So if you have high cholesterol and then your medical doctors say, oh, we could or could not treat it or wait a bit, I wouldn't wait. So when both of my parents had high cholesterol, I told them, take the statin. And I think that, again, in these medications, there might be even some protective effect. They still need to be tested, but there's some evidence for that. So hypertension, cholesterol, so, if you can do a checkup and then treat your vascular diseases, this is probably the best that we can do for now. And then maybe one last point that I want to stress, I think that we're probably going to be out of time, but we have these biomarkers in the research, right? So the blood biomarker, for example, they are not ready to go into clinic when you have no symptoms for many reasons, right? First of all, even if you're positive, you would need more tests. Second of all, we have no treatment to propose. So when I was talking about stress being a bad thing, right, I absolutely don't believe that knowing, for example, your p-tau217 status at the moment, even if you're positive, you might even be 15 years away, right? So we're not there. So whatever we do in the research takes some time to be translated in the clinic, but we're absolutely working on that.
Moltes gràcies. I farem bon cas, sempre és bona nota, crec, tots els que estem aquí, del que deia la doctora Villeneuve. Un aplaudiment per ella, sisplau. Gràcies per acompanyar-nos en aquesta edició del Brainfield Fest i gràcies per ajudar-nos a entendre l'Alzheimer abans que apareguin els símptomes, la importància de la detecció precoç, les estratègies del que parlàvem ara, les estratègies de prevenció que poden marcar la diferència en el futur. Després tindrem ocasió també, encara tindrem una segona oportunitat de fer-li preguntes a ella i a d'altres convidats. Ara continuem aquesta jornada amb una taula rodona titulada Afrontar l'Alzheimer en el futur, avenços, reptes i oportunitats. Una conversa per aprofundir en els avenços, però també en els reptes i oportunitats que tenim al davant, amb uns ponents realment de luxe. Crido ara, sisplau, a l'escenari a la senyora Hilary Evans-Newton. Sisplau, si pot pujar a l'escenari. El doctor Arcadi Navarro i el doctor Salvador Massip. On vulguin, poden seure on vulguin, tenen el micròfon al terra, trobaran ara el micròfon. I abans de donar la paraula als ponents i al moderador, permeteu-me que els presenti, malgrat que són ben coneguts per molts de vosaltres. La senyora Hilary Evans-Newton és directora executiva d'Alzheimer Research UK des de 2013. Sota el seu lideratge, l'organització s'ha convertit en una de les més influents del món en l'àmbit de la recerca en l'Alzheimer i demències, promovent de forma decidida la recerca innovadora i transformadora. El 2023 va ser nomenada copresidenta de la Iniciativa Nacional sobre Demència del govern britànic i l'any 2026 va ser reconeguda Commander of the British Empire per la seva contribució a la filantropia i a la recerca en demència. És un gran honor tenir-la avui amb nosaltres. Thank you, Hilary. It's an honor to have you here. Thank you. El doctor Arcadi Navarro, el coneixen molt bé, ja ho sé, però faré també 5 cèntims de la seva biografia. És director general de la Fundació Pasqual Maragall des de l'any 2020. Dirigeix també el seu centre de recerca, el Barcelona Beta Brain Research Center. És doctor en biologia per la Universitat Autònoma de Barcelona, catedràtic de genètica i professor i investigador i crea a la Universitat Pompeu Fabra. Com a investigador es dedica a la recerca en genètica de població i medicina evolutiva. Del 2016 al 2018 va exercir com a secretari d'Universitats i Recerca del Departament d'Empresa i Coneixement de la Generalitat de Catalunya. I moderant la conversa, tinc aquí al meu costat, el doctor Salvador Massip. Salvador Massip és líder del grup de recerca en biologia de la neurodegeneració i l'envelliment del Barcelona Beta Brain Center. És degà de la Facultat de Ciències de la Salut de la UOC i és professor de Medicina Molecular a la Universitat de Leicester. Metge i doctor per la Universitat de Barcelona, va treballar al Mont Sinaí abans de fundar el laboratori Mechanism of Cancer and Aging. És un gran divulgador de la ciència, ha publicat més de 40 llibres que han estat traduïts a 9 idiomes. És a dir, que ho deixo en les seves mans, senyor Massip, i endavant amb aquesta conversa, que després també tindreu oportunitat de fer-los preguntes no només tots tres, sinó a tots quatre. Gràcies, i endavant.
Moltes gràcies. Gràcies per venir avui aquest matí a sentir-nos parlar una mica d'Alzheimer. Per mi és un gran honor i un plaer estar aquí a l'escenari amb aquestes dues grans persones. Jo soc una incorporació recent a la Fundació Maragall i vull posar el meu granet de sorra amb tot això que sentíeu, aquesta xerrada fantàstica de la doctora Villeneuve avui per explicar on estem amb l'Alzheimer. Com veieu, hi ha canvis molt espectaculars, estem en un punt d'inflexió el que fa a la recerca sobre l'Alzheimer i, sobretot, amb el què podem fer per prevenir, tractar, frenar l'Alzheimer. Estem començant a veure tot el fruit de les últimes dècades de recerca en aquest camp. És un moment fantàstic, crec jo, per poder estar implicat en tota aquesta gran revolució que ens ve sobre en el món de l'Alzheimer. I avui volíem, en aquesta taula rodona, explorar una mica el que estan fent dues fundacions que són pioneres i que són capdavanteres en aquesta feina i que estan contribuint que la societat es pugui beneficiar de tota aquesta recerca. Thank you for coming today to talk to us about your work with the Alzheimer Research UK, Arcadi, your work with the Pasqual Maragall Foundation. To start, can we perhaps summarize a bit what's the role of your foundations? What are your goals? What are your aims? What are you trying to achieve with Alzheimer Research UK and the Pasqual Maragall Foundation? You can start.
Good morning. It's wonderful to be here and be part of this conversation. And I think these sorts of events and cultural events are so important that allow us to talk about the work that we're doing within our foundations. So Alzheimer's Research UK is the leading charity funding medical research in Europe. We are a biomedical charity, so we fund research in the UK, but across the globe. Ultimately, our purpose is to find a cure for the diseases that cause dementia, and we will do this by better understanding how we can reduce our risk and prevent the diseases, how we can better diagnose, and how we can ultimately treat. So we fund kind of across those three areas of science. But we also have a key role in terms of communicating where the science is, but also in terms of a fundraising charity. So we raise about £70 million a year. All of that is done through philanthropic donations, is to raise awareness of dementia and to talk to the public about the hope that research can bring. And for too long, dementia and Alzheimer's disease and the diseases that cause dementia were stuck in this sort of inevitable part of aging. People didn't understand the diseases of the brain, so wouldn't think of supporting a medical research charity in this space. So I think we have very much been sort of championing why we need to be investing in this as a charity, but why others need to be able to do that. So that's governments, that's philanthropy, that's all of the foundations around the world coming together. So that's what makes, I think, the relationship that we have really special.
Bon dia a tothom. Thanks for being here. I'll always use English for a second because I have to apologize to the both of you before I get started, because they got me right, but for some reason we remove your CVE, and for some reason even worse, we remove your PhD. T'hem tret el doctorat, Salvador. Però bueno, fora d'això, out of this, mireu, la Fundació Pasqual Maragall la coneixeu molt bé. Nosaltres som en aquests moments la ONG més gran de l'Estat, d'Espanya. Som molt petitons comparats amb els Alzheimer Research UK, però compartim amb els Alzheimer Research UK un somni. I el nostre somni és el d'un món sense Alzheimer, un món sense demències. I compartim amb els Alzheimer Research UK i amb la doctora Villeneuve un mètode per assolir aquest somni. Nosaltres volem que no hi hagi ni una sola persona que tingui un diagnòstic de símptomes clínics d'Alzheimer. el diagnòstic no ha d'arribar mai. I, per tant, el que hem de fer és detectar precoçment amb els biomarcadors digitals, biològics, en plasma, en imatge, amb la manera que sigui, detectar precoçment el risc i ser capaços d'intervenir abans que apareguin els símptomes de declivi cognitiu. Aquest és el nostre somni. Per fer això, intentem fer modestament el que fan ells. Intentem aixecar donacions filantròpiques, molts dels que sou aquí, sou part d'aquest somni a través de les vostres donacions, i intentem dur a terme projectes de recerca dins el nostre centre de recerca. Molts dels que sou aquí participeu en aquests estudis i, a més, darrerament també financem altres projectes de recerca que es fan fonamentalment a Espanya, molts a Catalunya, però també a Alemanya, a Luxemburg. Comencem a ser capaços de tenir un impacte global, perquè al final aconseguirem un món sense Alzheimer si aconseguim transformar la manera en què la ciència ha abordat la malaltia fins ara. Com la doctora Villeneuve ha ensenyat fa un moment, hi ha encara massa pocs assajos clínics amb fàrmacs preventius. N'hi ha molts més que no pas fa 10 anys. Fa 10 anys no n'hi havia gairebé cap. Ara n'hi ha uns quants. En necessitem molts més. A això ens dediquem nosaltres.
Thank you very much, a very good summary. I insisteixo també en el que diuen, crec que és molt important la implicació de tots nosaltres com a societat per poder fer avançar aquesta recerca. You mentioned a very interesting concept, which is the idea that until recently we assumed that dementia was part of aging. So aging ended in that if you lived long enough, you would be getting there. But we are now at a point where we may be seeing a difference between healthy aging and pathological aging, so aging with a healthy brain or aging with a disease. Now, what do we think that it can be the cause for this abnormal aging, for these people that would age poorly, that would go into Alzheimer's? What do we know nowadays in the field in terms of what could be the causes of people developing Alzheimer's or developing unhealthy aging or having a poor aging compared to people that would live to long ages with a perfectly healthy brain or perfectly... Do we have any clues of what can we do there?
M'acaben d'assignar la pregunta. El Salvador li feia amb ella, però ella m'ha mirat i... Teva. Les causes de l'envelliment són enormement multifactorials. L'envelliment és un procés natural. És el resultat de que la natura ens vol sants i forts de joves i el que procura és que puguem reproduir-nos molt, que puguem cuidar molt els nostres descendents i a vegades ens dona algun avantatge. Per exemple, un mamífer que sigui capaç d'absorbir molt calci de la dieta tindrà els ossos més forts i podrà amamentar millor les seves cries. Però aquesta acumulació de calci pot acabar desembocant en edats més avançades amb aterosclerosi, per exemple. I d'equilibris com aquests en el nostre organisme en tenim molts. I, per tant, totes aquestes coses que són dolentes, que acaben malmetent l'organisme, però que l'han fet molt potent, molt capaç de reproduir-se quan era jove, que tenen a veure amb l'inflamació, que tenen a veure amb que ens arruguem, el cabell se'ns torna blanc, adquirim tot de malalties inflamatòries, perdem massa muscular. Tot això, perquè jo els recordo, jo ara soc un senyor vellet, però fa 20 anys m'haguessin vist. Era bastant atractiu i tot, jo diria. Però tot es perd, tot es perd. Tot això també ens passa al cervell. També passa que el cervell va patint aquestes inconveniències que venen acompanyades de l'edat. El que passa és que és molt diferent un envelliment no patològic en què tu no trenques el fèmur, en què tu no agafes diabetis tipus 2, Però això és perfectament possible, ho tenim normalitzat. També ha de ser possible un envelliment cognitivament sa. El Salvador i jo vam tenir la sort d'estudiar genèticament la Maria Branyes, que fins que va morir fa poc, l'any passat, era la persona més vella del món. La vam estudiar als 117 anys, oi? Quan ella tenia 117 anys, li vam mirar la genòmica, li vam mirar l'epigenòmica, junt amb el Manel Esteller i una pila d'altra gent. I era una persona que havia arribat en aquesta edat amb un estat fisiològic i també mental propi d'edats molt més joves. Per tant, no només l'envelliment, que és natural, no té per què anar amb deteriorament cognitiu, sinó que segur que hi ha alguna manera que la ciència ens aportarà d'acabar sent als 120 anys tan joves com si només en tinguéssim 90.
I amb igual de cabell i...
Això ja... Amb això no s'hi treballa tant, diguéssim.
Estaria malament, també. Crec que és molt encertada la reflexió sobre com ja existeixen individus que són capaços d'arribar als 117 anys en perfecte o en gairebé perfecte estat de salut, mentre que hi ha altres que, com bé sabem, per desgràcia, desenvolupen Alzheimer o altres problemes abans. Poder entendre la genètica, l'epigenètica, tots els marcadors aquests que estem parlant, la proteòmica, per saber quina és la diferència i poder trobar quines són les característiques que fan que aquests individus arribin tan lluny i fins a quin punt podem la resta copiar-ho, amb fàrmacs o amb estratègies, crec que és un dels reptes d'aquest camp. Hem parlat, through the question to both of you, in the talk that we just saw, there were a lot of emphasis put on the biomarkers, on the new biomarkers of Alzheimer's. And interestingly, so there were some people with both positive tau, positive amyloid, developing Alzheimer's, people with tau developing cognitive impairment and Alzheimer's, people with amyloid. So these biomarkers are perhaps telling us a different story from what we thought before. Could it be that there are different types of Alzheimer, that we're using the word Alzheimer to define perhaps a series of diseases instead of just one disease? We always talk about Alzheimer's like we talked many years ago, or even now, about cancer, but cancer is 200 different diseases. Is Alzheimer also perhaps more complex than we think, and it's a set of different diseases that may require different treatments, may require different prevention?
So I think that's a really interesting point. And I guess it sort of talks to the fact that, particularly in the UK, we use the word dementia probably more than maybe in kind of Europe or in America. Whereas actually, I think in probably 5 or 10 years' time, we will start to talk about the particular disease. And actually, we'll talk about the disease that you may be diagnosed with or at risk of before you have the conditions that we're talking about when we're talking about people who are living with dementia. And ultimately, I think as a field, this is exactly where we need to go. So rather than sort of talking about someone who then is obviously from their symptoms that they're displaying, living with dementia, we talk about how we can understand some of the risk factors that Sylvia's just talked about, how we can then reduce those risk factors, but how we can detect, how we can diagnose way before we actually get to the point where someone is ultimately living with dementia. And that's where we want to get to as a field. So I think then we will talk about frontotemporal dementia, we will talk about what's happening vascularly, we will talk about Alzheimer's disease, we will then understand essentially the diagnosis that we are then giving someone, or the diagnosis, or the disease that someone is at risk of. And I think that helps us actually as a field entirely move away from this idea of an inevitable part of aging, or something that people find hard to maybe describe, or the stigma that surrounds it that aren't maybe within families and communities don't then come forward for the diagnosis, aren't getting the support that they need, to actually understanding the biology in the way that we would be talking about cancer, or we talk about breast cancer, where we're talking about a number of different diseases and we understand the genetics, we understand some of the different risk factors. And I think that's where we're moving to. But I think in your last question around causes, and I think the presentation earlier brilliantly showed this, there's still a huge amount that we don't understand. So yes, we do understand, and the Lancet study was something that Alzheimer's Research UK funded. So we can see what those sort of 14 odd risk factors can look like. We understand enough about the genetics, but that's probably 1% of people that are living with the condition where it could be purely genetic. That still leaves sort of 55% of the population, actually, if we reduced all of those modifiable risk factors, that we still don't know enough about. And I think that's where it comes back to the very point in the existence of our foundations, is to fund that science, is to fund that basic science, is to unpick some of those questions. And so I think it absolutely is a tipping point scientifically and as a society in the way that we are thinking about, or the way that we are talking about these conditions, and really bringing them out of the shadows, shining a spotlight on them, which they absolutely need. And I think this is very much the era of the brain. But we need to now understand some of those big questions. So we need to look at people who are living to 100 with healthy brains, with brilliant cognition, and understand, okay, what's happening with them. This is why we need these long-term cohort studies. But we also then need to understand, we were talking earlier about the impact on women. We need to understand far more about, why is it that 2/3 of people living with dementia are women? What does that look like? What is the impact of menopause? What's the impact of hormones? What are the environmental impacts that maybe impact women in a different way than maybe they do men? And when you look at stress and sleep, and as someone with 3 young children, you look at that and you think, okay, this is, I can see where some of these risk factors purely by kind of lifestyle can be a challenge maybe for from women in a different way than they might be for men. But there is still a number of kind of causational challenges that we need to understand, and this is why we need medical research. And I think the thing that charities, foundations can do in terms of the way that we fund research is that we are nimble. We can spot those opportunities. We can look to work with partners to maybe take a slightly more higher risk approach than institutional funders such as governments and others maybe would take. And I think that in the next sort of 5 or 10 years is going to be a hugely exciting area of science.
Jo recordo quan estudiava Medicina que estudiàvem l'Alzheimer, i això fa molt de temps, jo també soc una persona ja amb una certa edat, i el diagnòstic de l'Alzheimer ens deien que era post-mortem, es feia l'autòpsia. O sigui, tu no podies diagnosticar Alzheimer a una persona viva, perquè no teníem manera de fer-ho. Havies d'obrir el cervell i mirar què passava. Això ha canviat, com veieu, radicalment. Estem a l'era dels marcadors que ens permeten no tan sols diagnosticar l'Alzheimer, sinó començar a dir qui té risc d'Alzheimer fins i tot, o qui està començant a començar el camí aquest cap a l'Alzheimer. So, do you think that are biomarkers the key changing factor in this game? So in the last year, we're seeing a big change in Alzheimer's research and in Alzheimer's in general. Is this big achievement of finding biomarkers that can diagnose Alzheimer, but also predict the early stages and even predict risk factors and so on? Is this the big game changer? Is it now? Is it in the future? So do we need to keep investing in more biomarkers? I'm biased because I work on biomarkers, so I may have a vested interest here. But do we think the biomarkers is really what is changing the field?
I think it's changing it rapidly. And I think I guess sort of going back to the sort of way of how we think about the disease, actually, if we start thinking about this as a disease of midlife, we just don't see the symptoms till later life. And the biomarkers and a straightforward blood test enable us to understand those at higher risk. I think ultimately as a diagnostic tool compared to PET scans and CFS scans and the cost, the complexity, the impact on people of those sort of invasive tests. Obviously, blood tests are transformational for a health system approach. I think what's really exciting at the moment is what that unlocks in terms of clinical trials. So for years, and I've been working in Alzheimer's Research UK for a number of years, but before that I worked in aging, and we essentially had sort of years and years of clinical trials results that were were negative, where we didn't have the hope, we didn't have the investment from pharmaceutical companies because it was expensive and complex to run clinical trials in this space. And actually, I think the biomarkers and the blood tests help us unlock that, because then we start to think about getting the right people in these clinical trials, which actually probably for a long time we didn't have the right people in these trials, and we had them in the trials far too late. So you don't want people with early stage Alzheimer's disease in some of these trials. You need people preclinical in these trials. So the only way that you're going to be able to find them is through blood tests, maybe some of the sort of digital cognitive tools and a combination of these things. But I think that from a research perspective actually unlocks our ability to test and think about what those treatment pathways will be. So I think that's transformational from a scientific perspective, but from a patient perspective, then absolutely a simple blood test and the ability to get that quick, fast diagnosis before your symptoms before you're symptomatic is absolutely key, because we have two licensed treatments. We have 2 drugs in the UK that are licensed but not available on our National Health Service, and obviously it's patchy around the globe in terms of access to these 2 medications, but there are medications there that we can see, if taken early enough, can remove, are removing the amyloid and can help people stave off some of the symptoms for a number of months, if not years, and we're gaining the evidence on that. We also get better evidence in these new drugs from some of these biomarkers as they develop.
Sí, completament d'acord. Afegeixo que els biomarcadors ens posen en un camí molt interessant, perquè no és només el camí de detectar el risc d'hora, que ja podríem ser capaços de fer-ho, és també el camí de tenir un diagnòstic precís, que això ja ho estem fent ara en els hospitals d'aquest país. Ja no fa falta fer-se un PET o una punció lumbar per tenir el diagnòstic quan tens símptomes. Ja pots fer-te una analítica. Aquest camí és un camí interessant que després porta a més avenços. Porta a seleccionar bé els participants a uns assajos clínics o altres, porta a ser capaç de predir no només el risc, sinó també el moment en què s'esdevindrà la transformació, el pas a tenir símptomes. Abans, a la xerrada de la doctora Villeneuve, ho hem vist. Arribarà un moment que serem capaços de dir, miri, vostè té aquest nivell de biomarcadors i per tant vostè té 15 anys per davant de bona salut cognitiva, encara mirarem d'allargar-ho amb alguna intervenció, però vostè té aquest altre nivell de biomarcadors i per tant poder estar a 5 anys que li passi alguna cosa. Això és un camí molt interessant i també encara hi ha una quarta cosa que podem arribar a assolir amb els biomarcadors, que és el que ha passat també amb altres malalties. Fins fa 7 o 8 anys encara les persones rebien el diagnòstic de la malaltia de Crohn. Però ara, poder algú de la sala el va rebre alguna vegada aquest diagnòstic, però ara aquesta entitat mèdica, aquest constructe, s'ha separat en 2 malalties diferents. La malaltia inflamatòria intestinal i la colitis ulcerosa. I per què? Doncs perquè hi ha un progrés diferent de la malaltia, hi ha una simptomatologia lleugerament diferent i perquè tens biomarcadors que t'indiquen si una persona està en un escenari o en un altre. Poder la malaltia d'Alzheimer, que com sabem progressa de manera diferent en diverses persones, que avança més ràpid o més lent, que avança a vegades amb uns símptomes molt més punyents que no pas d'altres i a vegades viceversa, poder, gràcies a aquests biomarcadors, gràcies a aquests estudis més precisos, també la podrem anar separant en formes diferents de la malaltia. I això no es fa perquè sí, es fa perquè, a part de que classificar és bo, això vol dir que tu després has de poder fer intervencions diferents, has de poder fer accions diferents, fàrmacs diferents, tractaments diferents. I tota aquesta via la podem iniciar pel que tu deies abans, perquè ara ja el diagnòstic no el fem només després de morts, sinó que el podem fer molt abans. I per tant, doncs d'aquí uns anys serem capaços de donar-li a cada persona allò que aquella persona necessita.
Hem fet un exercici d'anticipació pel que fa al diagnòstic, sobretot. O sigui, estem predient com canviarà el diagnòstic en el futur en els propers 15 anys o propers 10 anys a l'Alzheimer. Anem a fer també l'exercici d'anticipació pel que fa als tractaments. Cap on veieu que va els nous tractaments de l'Alzheimer? New treatments for Alzheimer, where are we, what's the goal? Where are we going in terms of this? We saw this big development in terms of biomarkers. The revolution on treatment is still pending, or we're starting it. I mean, as you mentioned, we have the first drugs now targeted drugs for Alzheimer's. What's the outlook for the next 15 years? Quina previsió tenim, quina gran revolució tindrem en tractaments en el futur, o que pugueu preveure vosaltres des de les vostres fundacions?
So I do think the point at where we're at, it's a tipping point for this condition, and I think the next 5 or 10 years we will have that pull through from the medical research and the scientific understanding, and then how we bring that into health systems. I think that'll be the bit that really transforms, and we can see, the advent of quick, simple blood tests will transform a diagnosis. The understanding of the condition and the need to go much, much earlier will actually force, I think, from a sort of health system perspective and a scientific perspective, to think about this from midlife onwards, where we actually are getting to the point where we need to understand our risk, we need to detect and diagnose people who are at higher risk, and there needs to be treatments available for them. So there needs to be a really clear pathway and support along the way, where there are interventions, where there are treatments, where we understand the trajectory of the particular disease that someone is at risk of or diagnosed with. But it needs to be seen in the whole. There isn't a sort of silver bullet magic pill that is going to be available for these diseases. In the same way that we've made reference to cancer, we need to understand how better that we can reduce our risk. And as you'll have seen, there are so many different ways where there are, through our entire life course, ways of reducing our risk. So we need sort of public health campaigns, we need government support, we need health system support to be ensuring that from the first early years of children's lives, that people are understanding what they can do to look after and protect their brain. And I think it probably has been this sort of, in terms of an era of the brain and the sort of frontier at thinking about the brain, we've not thought about it in that way. We understand pretty well now the things that we can do to look after our cardiovascular and our heart health. So actually, if we use those messages of what's good for the heart is good for the brain, and we start thinking about how we can look after brain, we know that that is going to reduce some of the instances of dementia. But we are all living longer as a population, and so we need to ensure that there are clear strategies about how we're going to think about this condition, and then we need that investment from governments and from health systems, and of course continued medical research and scientific understanding. But we need to see that then played out so that we have the benefits in society of the scientific advances that we have now, so that in 5 or 10 years' time, I would want to see everyone getting an early and accurate diagnosis, everyone understanding what their risks were. And I think for probably some of the maybe rarer forms of dementia, actually we are starting to think about sort of gene therapy. We're starting to look at very different ways of being able to treat some of those conditions, where actually you could see actually a cure isn't that far off. And I think, that sort of hope isn't where we were 10 years ago. And I think, we often talk about cancer, we often talk about cardiovascular disease, we think about the different sort of pathways, we think of where the science is. We've done some work to sort of track where cancer was, and then map where we are in a sort of in an Alzheimer's field. And actually 1992 was the date that we saw in terms of scientific understanding, in terms of kind of what patients were offered in terms of clinical trials, in terms of research. But we don't want to wait as long as patients have had to wait to now in terms of the outcomes that people face when they're diagnosed with dementia, and early detection just being part of what we understand as being beneficial for people with cancer. So we need to get there faster. we've got a clear, I think, sort of roadmap as to how we'd want to do that. But we can only do that if everyone really pulls together and the pressure continues to be there. So I think for us, I think, yes, absolutely, it's about the science, it's about the investment, it's about the health systems. But actually, we can't do research unless we've got people participating in research. So making it easy for people to participate in research, supporting people to do so, and to ensure that we continue to have a really diverse range of ways of thinking about this. And so I guess back to the previous conversation, what we want to see are essentially as many shots on goal in terms of the different ways that we can think about this condition as possible. And we need that investment so that sort of big circle, actually we've got a sort of consistent pattern in terms of what we're investing in and how we're doing that. And I think that's where medical research organisations can take that holistic approach and ensure that we have funding schemes and that we can partner and we can work to spot where those opportunities are.
Fully agree. No silver bullet. We need people, we need investment. I és que és una cosa que me l'heu sentit dir molt sovint, no? Que la ciència no falla mai. La ciència, sempre que li donem un problema, el pot solucionar. Ara, cal talent, i això són persones, i cal inversió, i això són recursos, que moltes vegades no ho sembla, però els recursos també els posem les persones, sigui via donacions o sigui via impostos. Però vaja, me'n vaig a la teva pregunta. Nosaltres no podem predir el futur, però sí que podem imaginar com volem que sigui el futur, com fora millor aquest futur i podem actuar per construir aquest futur. I la teva pregunta de cara a futur, quin serà el panorama d'aquí 15 anys, jo m'atreveixo a dir dues o tres coses. La primera, d'aquí 15 anys haurem acumulat ja molts èxits col·lectius. Les inversions i les persones, tant les que fan donacions com les que participen en estudis, ens hauran portat a un èxit col·lectiu en el que hi haurà tractaments diversos per l'Alzheimer. Per què insistim tant ella com jo en tractaments diversos? Perquè l'Alzheimer no és com un home llop, que només el pots matar amb una bala de plata. L'Alzheimer és com un vampir, que el pots matar amb aigua beneïda, amb alls, amb una creu, amb una estaca al cor, ensenyant-li el sol, en fi, Déu-n'hi-do. Hi haurà moltes maneres d'abordar l'Alzheimer, perquè l'Alzheimer és una malaltia complexa. I el que acabarem sent capaços és d'aquest cercle que abans ens ensenyava la Sylvie, la doctora Villeneuve, en què hi ha una pila de tractaments. Nosaltres, tots, els que som aquí, que seguim una mica aquest tema, tendim a focalitzar en tractaments per netejar les plaques d'amiloide, tractaments per netejar els cabdells de tau. Però si ens hi fixem en aquest cercle, també trobem altres estratègies terapèutiques diferents. Estratègies terapèutiques que poden ser indirectes, evitar la hipertensió. Si els medicaments que eviten la hipertensió tenen un efecte també directe sobre evitar l'acumulació d'amiloide, poder sabem que els hi podrem donar a algunes persones. Fàrmacs que ajuden a controlar la gestió de l'energia per part de les neurones. Aquest també és una via de tractament que pot acabar funcionant. I n'hi ha moltes d'altres, no us avorriré. Però què passarà d'aquí 15 anys? Que no només tindrem un parell de fàrmacs aprovats que ni a Anglaterra ni a França cobreix el sistema de salut. I aquí ja veurem, s'està discutint ara. No només en tindrem un parell d'aprovats, en tindrem molts més d'aprovats. I aquesta és una situació que serà el resultat de la feina que estem fent entre tots.
Voldria destacar una cosa que deia la Hilary, que estem en aquest moment en la recerca de l'Alzheimer, o en el camp de l'Alzheimer, on estava el càncer a mitjans dels anys 90. O sigui, portem 30 anys de retard pel que fa a l'Alzheimer, comparant amb el càncer. I amb el càncer vam veure en el seu moment, sobretot des del principi d'aquest segle, com ha canviat radicalment el tractament, com la supervivència s'ha disparat i tot gràcies a la inversió, gràcies als esforços de la recerca. Ara estem en aquest punt al qual la recerca per l'Alzheimer està començant a treure fons, està començant a treure interès del públic, dels governs, i veurem segurament aquesta revolució que vam veure amb el càncer, la veurem en aquests propers 10 anys. Com deia la Hilary, també esperem que sigui més ràpida, que no haguem d'esperar 30 anys per estar com estem ara amb el càncer, puguem fer-ho amb 10 o 15 anys o menys, fer aquesta gran revolució que ens ve a sobre, i segurament quan ens veiem d'aquí uns anys tot això haurà canviat. Estem veient cada any, un any per altre, està canviant tot radicalment. Ja per acabar, que tenim només uns 5 minuts, amb aquest panorama, tot el que m'ha estat dient, veieu que juga un paper molt important les fundacions, perquè molta part d'aquesta recerca està sent aixecada des de baix, des del públic. O sigui, no és l'Estat que ens la dona, sinó som nosaltres, com a persones vehiculant-ho a través d'aquestes fundacions, les que estan aixecant això. Mentre que amb el càncer, per exemple, hi ha molt d'inversió estatal, amb Alzheimer potser encara ens falta aquesta inversió, i és una de les feines que tenen les fundacions, que és alertar d'aquesta mancança i atraure finançament. Com veieu el paper de les fundacions, de les vostres fundacions, en els propers 15-20 anys? Seguirà sent la base de la recerca o de la inversió de l'Alzheimer? Ha de seguir venint de la gent, del carrer, de nosaltres, de la iniciativa popular? Hem de pressionar més els governs perquè facin aquest canvi de mentalitat, potser que encara no hem vist. Com veieu la vostra feina? I tant de bo poguéssim dir que d'aquí 15 anys o 20 anys ja no farà falta fundacions, però com veieu la vostra feina els propers anys treballant per fer avançar aquesta recerca i aquesta millora en els tractaments i el diagnòstic de l'Alzheimer?
Let me get this one first so you can close up. Nosaltres tenim dues perspectives. Primer de tot, no hi ha res que fem els humans que no ho facin les persones. És a dir, deixeu-me dir, la recerca sobre càncer l'estem finançant tots els que som aquí. La recerca sobre Alzheimer l'estem finançant tots els que som aquí, sigui a través dels nostres impostos, sigui perquè fem donacions o sigui perquè comprem un medicament a la farmàcia i els beneficis acaben servint per fer més assajos clínics. Per tant, tot ho fem les persones. El problema que tenim, i és el problema que estem combatent, és que la recerca en demència a Europa, a Espanya, està molt mal finançada. I és per això que ens hi hem de posar les persones no indirectament a través de les nostres compres, no indirectament a través dels nostres impostos, sinó molt directament a través de la nostra activitat. Nosaltres el que creiem és que d'aquí 15 anys no només aquesta activitat seguirà sent necessària, sinó que pel camí, part de la nostra feina, part de la nostra missió, haurà estat convèncer a més persones i convèncer també a les autoritats que posin els recursos necessaris. La diferència és abismal i nosaltres hem de treballar per cobrir aquesta diferència. Us dono un exemple només. En els Estats Units, la financiació pública per recerca és molt més gran, o ho era, ja veurem com evoluciona això. El promig d'inversió en Alzheimer, en demència, perdoneu, dels últims 5 anys, el promig anual han estat 3.000 milions de dòlars. Ara anem a la Comissió Europea, això és el que invertia l'administració Biden. Ara anem a la Comissió Europea, el que està invertint l'administració von der Leyen. El promig anual són 93 milions d'euros. 93 milions versus 3.000 milions. Qui està treballant a Catalunya, al Regne Unit, a Europa, perquè aquest gap es cobreixi? Nosaltres, no només a través de les nostres inversions directes, sinó a través també de la mobilització social i de l'advocacy que volem fer perquè els ministres, perquè els presidents del govern, perquè els presidents de la Generalitat, perquè els consellers s'adonin que és imprescindible invertir en aquesta malaltia. Si no hi ha inversió, no hi haurà solució.
So I think the role of charities who are funding the medical research is obviously absolutely key in terms of the research that we fund. And I think the other side that we have a powerful role to play is holding others to account. And so, yes, it's absolutely, it's government, it's European, it's global funding, and ensuring that we are telling the story of hope, and we are giving them that roadmap as to what this can look like. And I think that historically we haven't necessarily had that. So we haven't had that path ahead of us where we're saying, this is where we need an investment, this is what it needs to look like, this is how you come together. And I think there are certain structures now in the sort of Alzheimer's field that are helpful in terms of bringing us all together. There's a World Dementia Council. There's been a focus from G7 meetings, G20 meetings. And I think those sorts of things structurally in government are useful to us in terms of providing us with a platform. I do think there's a clear benefit to foundation funding through medical research I referenced before. We can invest in the sorts of research that some of the state funders can't. We can be quick in terms of our response. We can fill gaps that others can't. We can bring industry players into this. We can collaborate in more innovative ways. And I think all of those things help us get to our ultimate goal much, much faster. But we also have an opportunity and a platform to bring the public with us, to support people to come forward and to participate in research. If no one participates in research, we can have some of the best therapies in the world, but we don't know if they work or not. And so I think we have a really clear role in communicating the opportunities of being part of research, the benefits of research, but also in terms of then holding everyone else to account. And I think that the sorts of research that we fund, because we are funded by the public, we have that patient benefit absolutely at heart of what we do. We are not funding science for science's sake. We are funding it because we want this to have an impact, and we will hold on to that, and we will ensure that the science that we're funding delivers that impact as quickly as possible. But we will also hold everyone else to account in doing that. So we will ensure that actually, if there are treatments, if there are diagnostic, if the blood tests, they need to get to people, they need to be in clinics, they need to be in our health systems, and we will continue to campaign and provide a platform to doing this. So I think that the charity landscape is sort of multifaceted in terms of the different roles that we can play. And I think that's what makes it dynamic, that's what ensures that we actually make that sort of progress.
Thank you very much. I think that's very interesting. Moltes gràcies a tots dos per donar-nos aquest punt de vista de com està la situació. Tenim una estona ara per fer preguntes. Aprofiteu que tenim aquí dues de les persones que saben més sobre Alzheimer i sobre com van les coses per fer unes quantes preguntes. Comencem per allà.
Bueno, gràcies, moltes gràcies, doctora o professors, doctors. La pregunta ja la volia fer, o el comentari volia fer en la primera intervenció, però he quedat fora de temps i m'ha anat molt bé perquè ara heu fet al·lusions per part dels tres. Primerament ho ha fet la doctora i volia exposar la realitat. Jo he format part d'un estudi, ho dic que exposo perquè com que hi ha dues persones que pertanyen a la Fundació Pasqual Maragall, jo vaig formar part fa, no sé, 3 anys possiblement, 3 o 5, d'un dels estudis del PENSA de la Fundació Pasqual Maragall i jo soc una de les APOE4, que ho porto amb mi, clar, per antecedents familiars, en fi. Tenia símptomes i segueixo tenint símptomes. Nosaltres vam acabar fa aquests anys i la realitat que després ens hem trobat és que per part d'alguna de les companyes o companys de l'estudi sí que han tingut sort que al anar a l'ambulatori, a la xarxa sanitària de la Seguretat Social, han tingut la sort de trobar algun metge de capçalera que els ha derivat a l'especialista o bé a un centre hospitalari per fer alguna prova més. Altres no hem tingut aquesta sort perquè em sembla que hi ha un gran desarraigo i molta separació entre els estudis, la recerca, formar part dels estudis voluntaris com hem format part, però després jo en concret vaig demanar inclús al neuròleg que ens va portar en aquest any que vam fer d'estudi algun paper perquè seguia amb alguns símptomes i per antecedents familiars soc una de les que tinc l'espasa. Llavors vaig demanar algun document i no, a mi ja se'm van dir que vam acabar l'estudi i que anéssim a l'ambulatori, que més o menys que s'espaviléssim. Dit crudo i tal. La qüestió és que jo en concret vaig insistir i no va haver-hi forma, perquè el meu metge en qüestió, que no és un metge bastant bo, però en totes aquestes històries, com que suposo que que la red no està molt treballada, encara estic al mig.
Sí, moltes gràcies per la intervenció.
De res.
Li diré, quan acabem una cosa concreta, vostè i jo, però deixi'm respondre primer en genèric. Hi ha una cosa que és absolutament urgent i nosaltres des de la Fundació Pasqual Maragall hi hem començat a treballar l'any passat, que és aquesta connexió que ha d'haver entre la recerca i els centres de salut. Això és molt important, perquè a vegades hi ha endarreriments. Aquí a Catalunya, per exemple, aquest diagnòstic precís que es fa amb la fosfatau 217 ja es fa de manera normal, però és que aquesta mateixa setmana, abans d'ahir, uns companys de Saragossa em van haver de trucar dient, escolta, li puc dir al meu neuròleg que si em vol fer una punció lumbar pel diagnòstic, que me'n vaig a Barcelona? Dic, sí, digue-li, perquè ja veuràs. I efectivament, al cap d'un poc, ja li oferien no la punció lumbar, sinó l'analítica de sang. Cal transformar el sistema de salut i cal acostar la recerca molt ràpidament del laboratori al llit del pacient. Però encara hi ha una cosa que és la que l'afecta a vostè, que és encara més radical. I és que nosaltres a casa nostra tenim un sistema de salut que és extraordinàriament bo, dels millors del món. Però és bo quan tens una cosa aguda. Quan et passa alguna cosa que realment correm-hi tots, que s'ha d'anar amb presses perquè és gravíssim, perquè és una qüestió de vida o mort, pots estar tranquil, et pots posar en mans de la Seguretat Social que tot anirà fantàstic. No aniràs a cap lloc millor del planeta. Ara, quan són coses molt llunyanes dels símptomes aguts, el nostre sistema sanitari encara no respon de la manera que necessitaríem. Des de la Fundació el que nosaltres aspirem és a transformar el nostre sistema sanitari i el nostre sistema d'atenció social. I aquest pont en què vostè es troba segurament sigui sociosanitari, perquè el que passa és que més enllà d'una intervenció multimodal de canvis d'estil de vida, avui a una persona que comença a tenir símptomes clínics d'Alzheimer, avui no existeix cap medicament que li puguem donar. Màxim la podem fer participar en algun assaig clínic. Aleshores, hem de fer la recerca biomèdica que ens toca, sí, però a més, com apunta aquesta senyora, hem de ser capaços que aquesta recerca biomèdica arribi als hospitals, arribi a la primària, tan ràpidament com sigui possible. I respecte al seu cas concret, en parlem després.
Moltes gràcies. Tenim temps per una o dues preguntes, feu-les ràpid perquè puguem contestar-les. Tenir el micròfon allà ara.
Bon dia, moltes gràcies. Ha sigut un privilegi poder escoltar tots vostès. Volia fer unes preguntes relacionades, una a la part més estructural de la persona, més física, si té a veure en aquesta recerca que la doctora Villeneuve ens ha estat explicant. Jo volia preguntar sobre les dones. El cos callós, si influencia aquesta hiperconnectivitat entre un hemisferi i un altre, el que hi pugui haver-hi més problemàtica més endavant. Després, si podia haver-hi també problemes també relacionats amb el metabolisme, si una persona és hipotiroidea o hipertiroidea. Després també volia demanar si a l'assumir complements hormonals a partir d'una certa edat, no només els estrògens que a la dona li fallen, sinó també perquè hi ha moltes dones que a partir d'una certa edat comencen a fer testosterona, si aquesta testosterona és protectora o no. Aquestes són les meves preguntes. Després, un biaix també és social. Aquí a Europa, la majoria de dones de classe baixa i de classe mitja tenim doble jornada laboral. I si això també s'ha estudiat i es té que veure. I al final acabar amb un comentari, doctor Navarro, una mica cínic. Jo crec que si a nosaltres els 3.000 milions de dòlars ens els haguessin donat, poder els haguéssim fet servir d'una altra manera, perquè els americans l'han fet servir per votar amb un home que té una demència i que no té frens inhibitoris.
Sylvia, you want to take this one? That's a one address. That's made for you. Thank you.
Absolutely. Thank you. I mean, it's a complex question, right? And more research is needed. I mean, I think that this is a take-home. You know, I don't know if it's still a fact, but so, 50% of the planet is women, and then, since recently it was shown that only 0.5% of the science was looking at factor influencing the brain of women, right? So what we know right now about hormone therapies is that it's not good to take them late. So, so if you are past menopause, it's not the time to start taking these hormones to prevent Alzheimer's disease or to slow down any cognitive impairment. So I think that this is completely clear that if you start the treatment, too many years after you are in menopause or even perimenopause, it's not good. What the science is trying to look at right now, and we don't have the evidence yet, but is what about if you would take them in perimenopause? And also, treatment for menopause is not one treatment, there's many treatment, right? And then we think that maybe when you take them very, very early on, maybe it could be protective, still need to be tested, and we also think that maybe it could be even more protective in women who have menopause earlier, because we know that women who have menopause earlier, they're at greater risk of Alzheimer's disease. They are also the one with more vascular impairment related to menopause, such as hot flashes and things like that. So for them, maybe taking the hormone would actually have a protective effect on the vascular system, maybe on the inflammation, and then maybe on Alzheimer's disease. So that's kind of the take-home on hormones. So not after menopause, maybe before menopause. We need money, we need to study that.
Bon resum de la situació i molt bona pregunta també. Ens queda temps per una més, potser? Sí, doncs l'última, que tenim el micròfon aquí davant.
Hola, bon dia a tots. La meva enhorabona per la presentació d'aquesta ponència. Perdoneu per la meva petita confusió, potser, al comunicar-me. No soc un gran orador. Segueixo com a metge, que soc, l'evolució de la malaltia d'Alzheimer des de fa uns quants anys. I voldria parlar una miqueta del present real, no del passat, sinó del present, d'aquesta malaltia, en aquest moment a Espanya, a Barcelona, vulgueu. I voldria anar més al gra. He sentit parlar que hi ha les proves abans eren per via punció lumbar, per buscar la petau, ara es fa en via sanguínia, és un gran avanç, realment és important, és molt més fàcil. Veig cada cop més la relació entre la genètica i la malaltia, com és amb el càncer, o sigui, hi ha un cert paral·lelisme, suposo, entre càncer i Alzheimer, i potser s'hauria de potenciar també els estudis genètics, que això sí que es fa bastant bé per la via pública, però, bueno, això seria secundari. Voldria vaig al gra. He sentit parlar de medicaments nous, concretament he sentit parlar del DORA, no sé fins quin punt és preventiu o és curatiu en fases inicials. Després també he sentit parlar molt d'un que es diu N19. Suposo que heu sentit el que va. Ja no parlo dels fàrmacs més coneguts, són els donanebaps i lecanebaps, que això pel seu cost suposo que costa de ser administrat a a la població perquè té un cost molt elevat. No, voldria saber una miqueta aquestes coses. Si algú em pot contestar, us ho agrairé. I una vegada, la meva enhorabona a tots per la vostra activitat. Gràcies.
So I'll take with the DORA. So the DORA is really right now, it's a hypothesis, right? So and then the DORA would be for almost people in middle age. So the DORA should not be taken to treat Alzheimer's disease. I mean, it will probably not work when people have symptoms. And again, it's really in the phase of, we have an hypothesis, we're gonna try to test that. You know that there's 4 groups worldwide testing the same thing in the same moment, so it's promising. But again, the DORA, it's really like, we think that maybe in midlife, or maybe this could be protective. So it's really, we don't know if it's a treatment now, we don't know if it's a protective treatment. Work needs to be done on that, right? So that's one thing. I think that what is confusing, so what we have at the moment now are these anti-amyloid treatment, right? And I think that what is hard for these treatment at the moment is that I'm not a politician, so I'm just going to say it like that, but the field is not completely agreeing, right? So we see, because in part of the cost that it costs and then the benefit, right? So we see with these treatment a reduction of the progression of the clinical disease, so the symptom, by about 30%. Which for me is a big success. I didn't even thought that it would work, right? Because if you have followed my presentation, I thought that removing the amyloid when you have symptoms would just do nothing, right? You would be too far in the disease. So I was actually personally very happy when I saw that it worked that well. So, but 30%, it's not curing it, right? So I think that a lot of people were disappointed. So I was surprised, I was happy. A lot of people were disappointed. I understand that. This is one fact. I think that the other thing is that people got scared about the side effects. So when you remove the amyloid from the brain, there is chances in about, again, another third of people, let's say, that you will have, by removing the amyloid, some inflammation, some vascular diseases. Most of it is asymptomatic, but some people have died, right? So again, like cancer, you have side effects, we need to take them seriously. But there as well, let us, the scientists, help you there, right? Because we're super intrigued by these treatments, and now I can tell you that if we give them more slowly, we have less side effect. Again, most of these side effects are silent. The ones that have really bad side effects are usually the ApoE4 carriers. Again, we can have the discussion at the individual level and then give you the risk. And then the last part, and then I guess I'm going to pass it to you, but is that these treatments right now are extremely costly. And then I don't know the name in English, but for now you need to give them, I'll let you explain that part. But eventually it will be possible to give them like you do for Ozempic, or people will be able to self-inject it themselves. So as any treatment, this treatment is, maybe not as any, it's super expensive. But again, I think we need to start somewhere to be able to reduce the cost. So I'll let you follow.
Yeah, so I think the slide that we showed earlier, the kind of the big circle with all the clinical trials in this space, sort of 140 clinical trials in Alzheimer's disease. That's fantastic. So in terms of when I was saying we need more shots on targets, we have that. They're all at different stages. We have 2 licensed treatments. As Sylvia said, they're complex, and the cost is actually in terms of getting them to patients. So it's almost like having a kind of chemotherapy suite for Alzheimer's, where you need to go every 3 or 4 weeks to have your intravenous drip of lecanemab or donanemab. There are some side effects, and I think I would say the community have been kind of split and quite cautious maybe about some of that. In a way, we probably haven't been with chemotherapy. Chemotherapy drugs have awful side effects. And I think that part of this comes back to, if we're thinking about this as a neurological disease and a set of neurological conditions, we think about it quite differently. And I think that that's partly because we often aren't completely in that camp. And so actually, if we're talking about this in terms of the complexity of the disease, and this is the first generation of any kind of treatment, and really thinking about what that pathway from the next generation of diagnostics and blood tests to the first generation of treatments. When we've done it in other disease areas, we start small, we pilot this, we work in research, and we haven't done that enough, I don't think, in any country across the world. In the UK, I've been doing a lot of work trying to say, actually, how do we ensure that we've got a couple of research centres linked to some of the big hospitals where we can essentially pilot and test some of these new drugs, so we understand how we can give them safely and effectively to patient populations, how we can gather that data. But as we said, the next generation of these drugs is coming, so there will be self-injectables. Ultimately, it'll probably be a tablet. There's new drugs that essentially get the drug into the brain and through the blood-brain barrier, which has obviously been a challenge for a long time, through a sort of brain shuttle. So there's a drug, trontinemab, in later stage trials at the moment, and that is sort of likely to show sort of less side effects, potentially then to be more effective. And so I think you are going to see year on year safer, more effective therapies, and we will then pull the costs down. And we will understand, actually, as health systems, how to then diagnose and treat, because we've never done that in Alzheimer's disease. And it's pretty unforgivable, really, that actually as a society, on the large part, we've been quite happy to leave people to it on their own. If they're lucky, they'll get a good diagnosis. If they're lucky, they get some post-diagnosis support. But it's then often left to families, to carers, to then support people, pick up the pieces, and they end up in some sort of care setting or hospital when there's a crisis. Actually, we need a completely different way of thinking about this. So we need a pathway really from midlife, and in the UK, we managed to get in what is a National Health Service health check at 40. You are called in to see your doctor. One of the things they will talk to you about is dementia and dementia risk, and the things that you can do from your 40s onwards to reduce your risk. It doesn't always happen in the UK, but we want every health system to start thinking about it like that. So actually, as you get towards 50 or 60, what does a screening program look like? Could it almost be like a statin for the brain, that everyone routinely would then be taking something that ultimately is kind of preventative, and that ultimately is your treatment, that's your sort of North Star cure.
Moltes gràcies per les preguntes, crec que ha sigut molt interessant, i crec que el missatge final seria una mica quedar-nos amb aquesta idea que estem en un punt d'inflexió, estem en un punt que està revolucionant el camp, que venen canvis molt importants, que tenim la primera generació de fàrmacs i cada cop seran millors, tenim bons biomarcadors ja, cada cop podrem descobrir la malaltia abans, cada cop podrem fer més coses abans, i estem una mica al principi d'aquesta revolució a la qual tots nosaltres podem participar a través d'ajudar les fundacions, a través de tot el que estem fent ja. Gràcies per venir, gràcies per les preguntes, gràcies als ponents.